genetics. Again, we covered this as well. Here we have a comparison of the genetics involved in the beta globulin chain. We have a depiction here of the DNA sequence, the corresponding messenger RNA, and the amino acid that will be incorporated when the messenger RNA is translated. So we begin here with a normal nucleotide sequence here in the beta gene. We've got the beta A chain encoded forward by the beta globulin gene. Normally we'd have this sequence of CTC. That's going to get transcribed into messenger RNA, and that will be encoded in a GAG. This is a codon, single codon. The single trinucleotide codon gets read, and every time this GAG is read by the ribosomes, they're going to incorporate this glutamic acid in the beta globulin chain. Okay, that's normal. Glutamic acid, ionized acid, has a charge, very water soluble. However, sometimes this gene is mutated. Sometimes, for example, this thymine-based nucleotide is changed to an adenine-based nucleotide. So instead of the nucleotide sequence reading CTC, now it reads CAC. When that's transcribed, you get this messenger RNA with the codon GUG. The GUG codon encodes for a different amino acid of valine. Valine is very different from glutamic acid. Glutamic acid is very water soluble, valine isn't. And when you incorporate that valine into the structure of the beta globulin chain, the entire molecule of hemoglobin becomes less water soluble and it tends to polymerize. Okay. Now we've already discussed a couple of problems associated with the sickling of RBCs. Again, sometimes the RBCs of someone with sickle cell anemia are normal. All the hemoglobin molecules are separate and they're floating around. However, certain conditions, acidic conditions, low oxygen tension conditions, can cause the hemoglobin molecules that are mutated to polymerize. And that's when the RBCs will sickle. Start sickling, they start blocking blood vessels like this. You have a blood vessel bifurcating from a big caliber blood vessel to smaller caliber blood vessels. Sometimes these sickle cells, they don't deform enough and they will occlude the blood vessel. When this happens, you get infarcts, causes pain. That's called a sickle cell crisis. The sickle cell crisis is so painful, very often we have to give opioids to control the pain. And people with sickle cell anemia often get addicted to opioids as a result of trying to manage their pain with a sickle cell crisis. Okay, any questions on sickle cell anemia? Okay, other anemias. Some of these anemias are nutritionally based, the most common of which is caused by an iron deficiency. Okay, based on the RBC indices at the time the anemia presents, we can subclassify anemias into one of three categories. We've got microcytic anemias, we've got monocytic anemias, and macrocytic anemias. These different classifications are based on the volume of the RBC at the time the anemia presents. Okay? Generally, the normal RBC volume is somewhere between 80 and 100 femtoliters. 80 and 100 femtoliters. If someone develops an anemia and the volume of the RBC is less than 80 femtoliters on average, well, it's called a microcytic anemia. There are some common causes of microcytic anemia. The number one would be an iron deficiency anemia. Without iron, hematopoiesis is inefficient. The RBCs that are presented are relatively small and pale. The biggest cause for that's going to be an iron deficiency. Now, generally, we don't always consume enough iron in our diets. However, usually it's not necessarily the iron consumption that's the big problem. It's more like the loss of iron. Normally, we don't even lose a lot of iron. However, if we have a bleeding diathesis, we're losing a lot of blood, we're losing a lot of iron at the same time. That's very often the cause for iron deficiency anemia. Someone has a perpetually bleeding peptic ulcer, or a woman is having menorrhagia, heavy bleeding. Over the course of time, they develop a deficiency in iron because they've lost too much of it and they haven't replaced enough of it. Okay, that can result in iron deficiency. Easy to treat that. We just give a ferrous sulfate supplement, and if it truly is an iron deficiency anemia, they should respond very well. Less common causes of microcytic anemia include copper deficiency. Someone has a copper deficiency, it'd be kind of unusual, but would most likely they'd probably be treated with some iron, except that that treatment would not cause an improvement in the anemia. And when that happens, you have to start looking for other reasons for the anemia. And of course, another cause would be a vitamin B6 deficiency. Again, not a very common deficiency. Then we have the normocytic anemias. Could be caused by Korsakoff's disease, which is a protein deficiency. And then, of course, we have the macrocytic anemias. These are often caused by deficiencies in things like B12 and B9. The macrocytic anemia, the mean corpuscular volume would exceed about 100 femtoliters. All right, let's take a look at that. We're going to take a look at an iron deficiency anemia. Again, this would cause a microcytic anemia. The average mean corpuscular volume of RBC would be below about 80 femtoliters. Here's a nice illustration showing you what an anemia would look like. Here are the normal erythrocytes. They do have that biconcave discoid morphology. The center of the erythrocyte is rather thin, and as a result, when you look at the RBC, the center of the RBC looks very pale, the rim looks kind of hyperchromatic. Okay, that's normal looking. Here's what the RBCs look like with iron deficiency. They are, on average, smaller. They have a much smaller volume, and so they are a microcytic type of anemia. But you'll also notice the RBC color doesn't look as robust. You've got smaller RBCs, which are a little more pale, and that's because the rim of the RBC is a lot smaller, doesn't stand out as much, and overall the RBC looks a lot paler. And so we call this a microcytic anemia, but we can also add another descriptor to this anemia. We can comment on the color of the RBC, referring to its kind of lack of coloring. We call that a hypochromatic microcytic anemia. Again, one of the more common causes is iron deficiency. There are certainly other causes of hypochromatic microcytic anemia. And so hypochromatic microcytic anemia is consistent with an iron deficiency, but just keep in mind it's not diagnostic of an iron deficiency. You have to do some more workup to confirm that it's an iron deficiency. Now here's some actual blood smears. Again, I believe we looked at this in physiology as well. We got a blood smear here in normal limits. Over here we got an iron deficiency. Okay, we've got the RBCs, of course, throughout the smear, and for reference, we have neutrophils here that we can compare sizes to. And you can see, again, these RBCs look like they're good size compared to the neutrophil. They're about 8 microns in diameter compared to the neutrophils, which are about 15 microns in diameter. Good reference. Everything looks good. Biconcave morphology, you can see that. Everything looking good. Here, over here we got iron deficiency. And while we do see some normal looking RBCs, there are many RBCs that are very small. And again, it's the average size of the RBC we're looking at. The mean corpuscular volume, the average. Okay. And you can see, on average, the mean corpuscular volume of these RBCs is going to be much less than what we have over here. Also, you notice these RBCs kind of look pale compared to their normal counterparts. Normal counterparts have a hyperchromatic ring, okay, very thick. These look very pale by comparison. So we have hypochromasia and a microcytic cell. So it's a microcytic hyperchromatic. Yeah, consistent with iron deficiency. Okay, any questions on that? All right, let's take a look at some of our first pulmonary pathologies. First pulmonary pathology we look at is atelectasis. Atelectasis, you recall, is a condition that refers to collapsed pulmonary parenchyma. Specifically, the alveoli in the lung are not filled with air anymore. They're collapsed. That part of the lung parenchyma that doesn't contain air in the alveoli is described as being atelectatic lung. Now, there are several different causes of atelectasis. And based on the etiology of the atelectasis, we can subclassify atelectasis into generally one of four categories: resorption atelectasis, compression atelectasis, and contraction atelectasis, and also microatelectasis. Okay, let's take a look at resorption atelectasis first. We got a depiction of the pulmonary cavity here, outlined with a dash, and of course in pink we can see the pulmonary parenchyma, and in blue here we can see the respiratory tree. Resorption atelectasis is often caused by some sort of occlusion in the airway. You can see that airway is occluded. You have an occlusion in the airway. Distal to the occlusion, you don't get any air exchange, no ventilation of the alveoli. Now, initially the alveoli are filled with air, but blood is traveling through the pulmonary capillaries, and blood will extract air from the alveolus. And as that air is extracted from the alveolus, it's not replaced with any air. So gradually, the alveoli will collapse as a result of resorption. And so, this is called resorption atelectasis. Common causes of some sort of occlusion of the airway. You can have a foreign body. Kids aspirate all kinds of things, pebbles, peanuts, another common thing that they do. Adults, usually some sort of mucopurulent plug, some mucus mixed in with inflammatory cells will clog up the airway. Asthmatics do this all the time. Yeah.
Let's assume it did happen because of the peanut. Little kids swallowed the peanut, breathed in a peanut. What would you do? Is it something that needs medical intervention, or do you simply wait and see? If the child has some dramatic symptoms or signs, we might have to go with a bronchoscope and try to retrieve whatever foreign body they've aspirated. Okay, so it depends on the symptoms.
Yeah, it depends on the symptoms. Also, if you aspirate like a peanut or something, there is a chance that it could cause an infection as well. So we'd have to assess the situation. It might be so small, it's just you can't get at it. But they have a history of aspirating it. They don't have any symptoms at all. It might be so small, it's something very small. Atelectatic lung has a tendency to get infected, and so we'd have to watch that. But eventually, peanuts resorb also. For little kiddo's system would probably eventually resorb. If you have something else, like a pebble, we might have to go after that. Maybe a lavage, try to get it out with a lavage. Okay, so you have this resorption again, collapsed lung, that's resorption atelectasis. In adults, again, mucopurulent plugs, common, person's sick or has asthma. Sometimes during a surgical procedure where they're receiving the general anesthetic, anesthesia, the coughing reflexes of the lung are kind of slowed or abolished, and mucopurulent material sometimes will collect. Very common in the post-operative period for a patient to develop atelectasis of this type. Then we have compression atelectasis. Something's compressing the lungs. Often it could be some sort of effusion. You can have effusion in the pleural cavity, fluids collecting, and it'll push on the lung, and the lung will collapse as a result of compression. In patients who are bedridden, they're not using the full excursion of their diaphragms. The diaphragm tends to move upward and compresses the bases of the lung, and you get bibasilar compression atelectasis. Okay. Sometimes compression atelectasis can be caused by air being introduced in the pleural cavity. Remember that you need a subatmospheric pressure in the pleural cavity to keep the lungs expanded. Introduce air, the lungs' own intrinsic elastic recoil will cause the lung to compress and collapse. Okay? Then we got contraction or cicatrization atelectasis. This is often caused by scarring in the lung. Lung's highly developed structure. If the lung infarcts, a lot of the overall structure is destroyed, it'll scar down. It's not going to regenerate. Then you get the scarring, and that scar tissue will pull on some tissues, compress other tissues, resulting in some degree of collapse of a local area of lung. And then we have something called microatelectasis. Microatelectasis is usually the result of insufficient surfactant production. Surfactant is supposed to keep all the alveoli evenly inflated. A lack of surfactant production will result in some alveoli being hyperinflated, others collapse, and you get little microscopic patches of collapsed lung. So it's called microatelectasis. We can see microatelectasis in premature neonates, premature babies. One of the last tissues to mature in a baby prior to its birth is the lung tissue, specifically making surfactant. Child's born prematurely. Their lungs aren't making surfactant, and they often develop microatelectasis. It's actually a condition that's called atelectasis neonatorum. Let's take a look. Here's an example of a section of the lung from a patient died of atelectasis neonatorum. That's lung tissue. And you probably don't recognize it as lung tissue. Usually the alveoli are very recognizable in this section. Here, you probably don't recognize anything. That's because this lung is collapsed. When you were presented with a typical histologic section of lung, that section was taken when the lung was inflated with formalin. And it fixes in a kind of an inflated configuration. This is actually what collapsed lung looks like. The first clue that it's lung is here. Okay, that looks like a respiratory airway, and it's lined by a pseudostratified ciliated epithelium. And that, if I didn't catch that, I might be staring at that a while before I actually recognize some alveoli. There's an alveolus, but it's collapsed. And you can see that the alveolus is lined by squamoid cells. Those are the type 1 pneumocytes. All right, all the alveoli are collapsed here. This lung isn't certainly not exchanging much gas. Okay. Also, the blood vessels, the pulmonary capillary vessels, are all congested. They're all filled with blood. So this lung is not going to be very useful for gas exchange. Okay. Principal problems with atelectasis, obvious one being hypoxia. It's going to be very difficult to oxygenate blood with this, but also collapsed lung tends to get infected. Okay, any questions about atelectasis?
Dr. Maddie, in the compression section in the notes, you have that also patients with ascites. Is it because they don't push in, or because the fluid will actually seep into the pleural cavity?
Ascites will displace the diaphragm upward,
Okay.
so you get compression atelectasis.
Okay.
That would be another reason for biphase or compression atelectasis.
Thank you.
Okay. All right, let's take a look at main section of pulmonary diseases, obstructive and restrictive diseases. So we said that in physiology, based on the changes to various spirometric variables, we can subclassify pulmonary diseases into 2 categories. There are the restrictive pulmonary diseases and the obstructive pulmonary diseases. The determination of the pulmonary disease is solely based on the changes that we can assess with spirometry. Obstructive lung diseases are characterized by some sort of obstruction airflow.
It becomes difficult to move air in and out of the lungs, particularly during the exhalation phase. If it's difficult, there's clearly some sort of obstruction to airflow. Any disease that causes that would be classified as an obstructive lung disease. Then we have something called the restrictive lung diseases, another major category of pulmonary diseases. Restrictive lung diseases are characterized by a restriction in the ability to expand the lungs. Something is preventing the lungs from fully expanding, so they're restricted. We call it a restrictive pulmonary disease. You can determine a pulmonary disease and subclassify based on whether it's obstructive or restrictive by performing spirometry. There'll be distinct spirometric changes associated with each of these two major classes of pulmonary diseases. So let's take a look. We've got some of the most important spirometric variables listed here in the table for each of the two major divisions of disease, obstructive and restrictive. Let's first take a look at normal. Okay, so I pointed out a couple important spirometric variables, the forced vital capacity, the FVC, and the FEV1, the forced expiratory volume per second. Okay, normally, total lung volume is about 6 liters, but you can only displace, of that 6 liters, 5 generally. That's called the forced vital capacity. Breathe in and out as hard as you can, you're only going to move about 5 liters. That's the forced vital capacity. If you're asked to inhale deeply and expire as hard as you can, the first second you're probably able to expel about 80% of that, or 4 liters. Now, often we want to make sure that we are taking into consideration the size of the individual when we're measuring forced vital capacity and FEV1. Bigger people are going to have bigger lung capacities. Smaller people are going to have smaller lung capacities. Okay, we want to be able to assess and compare. So to do that, we have to normalize to some parameter of the person's size. Generally what we do is we normalize various measurements to the forced vital capacity. So, forced vital capacity is 5 liters, the FEV1 is 4 liters. We want to make sure the FEV1 is within normal range. All we have to do is normalize it to the forced vital capacity. We take the FEV1 and divide it by the forced vital capacity. That's normalizing it to the forced vital capacity. And we'll discover that the FEV1 is about 80% of the forced vital capacity. That's a normal proportion. So we know that person has a good FEV1. Okay. How about obstructive lung disease? Obstructive lung disease is a disease where the air is difficult to move in and out of the lungs. There's some sort of obstruction to the airflow, particularly during exhalation. Because when you exhale, the airways tend to collapse a little, make it a little more difficult to exhale the air than it is to inhale the air. Okay? The most important spirometric variable that changes as a result of obstructive lung disease is the amount of air, the volume of air that you can forcibly expire in the first second. And so the major change in spirometry, which characterizes these obstructive diseases, would be the FEV1. FEV1 is always reduced in an obstructive lung disease. The FVC might not change. The FEV1 over FVC, you will find is reduced. If normal is 80%, maybe this fraction will be, maybe 50% or less. That's abnormal, easy to assess. Okay? Reduction in the FEV1 is what characterizes the obstructive lung disease. How about the restrictive lung disease? What's the problem? You can't expand your lungs. If you can't expand your lungs, you can't take a deep breath. So, what spirometric variable is most affected? The FVC. The FVC would be most affected. You just can't inhale and move as much air. Now, usually the FEV1 is normal or reduced, but there's no increase in resistance to air flow in and out of the lungs with restricted lung disease. You just can't expand your lungs as much. But you may find that the FEV1 is also reduced. Why? Well, maybe there's such a reduction in the FVC that the amount of air you can exhale in the first second is reduced simply because you can't inhale as much air. How do you determine what's what? You take the ratio. Again, whatever you inhale
you should be able to exhale 80% of it in the first second if there's no obstruction to airflow. And if you do that, you'll find the FEVC, FVC ratio is normal, it's about 80%. Meaning that even though you have a reduced FVC, you can still exhale 80% of it in the first second. So that's why we have these ratios. Ratios are there to normalize the parameters, yes.
In the notes, for obstructive, it says normal or increased FVC.
Yes, that's understandable. You can just ignore the whole thing, it's usually what's wrong. And that's it. I forgot I had that not correct in the notes. Okay. What page is that on?
4.
Page 4 at the bottom?
Yep.
At the bottom page. Okay. All right, so we know what basic spirometric variables characterize each one of these main pulmonary diseases. And these are the most broadest way to subdivide the pulmonary disease into obstructive and restrictive. They can be further subdivided based on the timing in which these symptoms develop. And as such, we have acute and chronic obstructive, and we have acute and chronic restrictive. A problem develops in just a few days, that falls under the acute category. Something takes a little longer, takes years, well, that's more chronic. Okay, there's some general characteristics of acute and chronic we want to talk about. Okay. Any questions on that? All right, let's talk a little more about acute and chronic categories of these things. Okay, just in terms of generalities. If you learn these generalities, you probably won't even have to bother learning a lot about individual diseases, because you can just draw from these generalities. Okay. Mentioned obstructive, primarily characterized by a reduction in the FEV1, restrictive, primarily characterized by a reduction in the FVC. Restrictive diseases can be subdivided into acute and chronic. Acute restrictive lung diseases, they usually develop within a few days. Something has to happen to reduce the lung compliance in a few days, preventing the individual from fully expanding the lungs. This is usually caused by inflammation infiltrating the interstitium of the lung. Remember, that's the wall of the alveoli? You get a lot of junk in the wall of the alveoli, that's going to reduce the lung compliance. And it can happen relatively quickly. You get some inflammation in the interstitium, the lung is not going to expand the way as it did before. Its compliance is low. It's very difficult to expand it. So naturally, you're going to get a restrictive lung disease very quickly. We call that an acute restrictive lung disease. Now, most restrictive lung diseases develop quickly, but they're transient in nature, meaning they'll resolve. Example, you have inflammation in the interstitium, that's going to cause a restrictive lung disease acutely. But the inflammation can resolve, eventually go away. And you can regain the compliance of the lung that you once normally had. Okay? Well, that would be an example of an acute restrictive lung disease. Quick onset, transient, it healed itself. Sometimes, though, restrictive lung diseases develop insidiously, meaning over a long time, and they're not reversible. These are the typical features of chronic restrictive diseases. Chronic restrictive diseases usually develop slowly. Whatever happens, it's not reversible. Most common cause for a chronic restrictive disease is some sort of scarring process in the interstitium. The walls of the alveoli scar down. Normally those walls are very elastic. What if you load them up with scar tissue? They're not distensible anymore. You can't stretch them anymore.
it takes a long time for that scar tissue to develop. So, with a chronic restrictive lung disease, scar tissue develops slowly, the lung slowly loses compliance, and you slowly lose the forced vital capacity because of the restriction. Now, once all that scar tissue is in your interstitium, you can't get rid of it. There's no way to change it. There's no way to remove that scar tissue. And so there's an insidious decline in the forced vital capacity, and it's not reversible. That characterizes most chronic restrictive lung diseases. Most chronic restrictive lung diseases are caused by scarring in the interstitium of the lung. Slow to develop, permanent. How about obstructive lung diseases? Difficult to exchange air. Again, you can have acute and chronic. Perhaps there's something going on with an airway. Maybe there's a sudden inflammation that develops in the airway. Maybe the airway gets all edematous and it kind of gets spastic, kind of contracts. That smooth muscle that controls the caliber of the airway goes into a spasm and clamps down. There's going to be a sudden increase in resistance to airflow. Okay, well that's going to affect the FEV1 quite dramatically and quite quickly. Whatever's doing that, it's causing inflammation of the airway, causing it to go into a spasm. That's going to present with an acute obstructive lung disease profile. The inflammation causing the airway to narrow. The inflammation developed quickly, so it's acute. But you know the inflammation can resolve. It can resolve almost as quickly as it developed. And so the airway can relax, and can become less edematous and expand. Well, that acute obstructive lung disease is transient. Quick onset, short duration, resolves. Acute obstructive lung diseases are usually quick and transient. Quick to develop, and they resolve. What else can happen to cause a more chronic form of obstructive lung disease? Again, maybe the airways become very flimsy, scarred down. They don't remain patent during exhalation, and they're scarred, so now they're stenotic. It's going to definitely affect the FEV1. That scarring process probably develops slowly in the airways. And so it's kind of an insidious onset. A gradual decline in the FEV1 as the scar tissue in the airway constricts the airway or strictures the airway. It's going to take a long time for the scar tissue to develop. And so it's going to take a long time for the FEV1 to reduce. But once that scar tissue is formed and the FEV1 is reduced, you can't get rid of the scar tissue. So it's insidious, but it's permanent. Okay, that are the general features of chronic obstructive lung disease. Okay, so some good generalities to remember. Again, if you have a specific disease in mind and you forget, how is this disease classified? Is it obstructive? Is it restrictive? Is it acute? Is it chronic? Just think of the disease's features and you'll probably be able to take a guess. Okay. All right, any questions on that? Right. We're going to start exploring a number of different common obstructive and restrictive pulmonary diseases, both acute and chronic. And we're going to start with asthma. We'll talk a little bit of asthma and physiology. Asthma is this condition where a person's airways are chronically inflamed. Airways are infiltrated with all kinds of inflammatory cells. This inflammation makes the airways very irritable. And when the airways are irritable, they have a tendency to go into a spasm from time to time. Now, this chronic inflammation is kind of mild, generally. Doesn't cause the airways to stricture, but it's certainly causing the airways to be irritated. The airways are normally patent. The person can breathe in and out without much of a hassle. But if there's one more thing
that insults those airways. One more thing that irritates those airways. Those airways just might go into a spasm and clamp down. And then suddenly, it becomes very difficult to breathe. There's a sudden reduction in the FEV1. That's what characterizes asthma. Asthma is classified as an acute, obstructive lung disease. Most of the time, people with asthma are fine. They can breathe just fine. But when they're having a spasm in their airways, i.e. when they're having an asthmatic attack, it becomes very difficult to move air in their airways all of a sudden. Now, eventually, we can get the airways to relax. Either they'll relax on their own, or we can administer some sort of smooth muscle relaxant for the airways. It's usually a beta-2 adrenergic agonist called albuterol. Okay, give them that, relax the airways relax, they're not spasm anymore, they open up, and the air can be exchanged easily again. So an asthmatic attack doesn't last very long. So, onset of an asthmatic attack is very quick, but it's reversible. So you get a quick drop in the FEV1, you can reverse the condition, and you can restore the FEV1 value. That's asthma. So asthma is classified as acute, obstructive lung disease. Quick onset, short period of time it lasts, and it can resolve. Okay. A couple of things about the airways of an asthmatic. They're inflamed. If you analyze the inflammatory infiltrate of those airways, it's comprised of a lot of different inflammatory cells, lymphocytes, macrophages, neutrophils, but there's one white blood cell in particular that's present in those airways that you typically don't see in other diseases associated with airway inflammation. The eosinophil. The eosinophil. In that inflammatory infiltrate, in the airways of asthmatics, you see the eosinophil. The eosinophil is basically not present in any other disease except asthma. The eosinophil plays a very important role in the pathogenesis of asthma. It's important to remember. Okay, let's talk a little bit about some generalities. The airways of an asthmatic are described as being hypersensitive, overreactive, hyperreactive airways. Again, they're already inflamed, they're irritated. You irritate them a little more, they go into a spasm. Okay? Now, usually when someone's having an asthmatic attack, they can inhale, but when they go to exhale, their strictured airways collapse even further, so it's very difficult to get the air out. There's so much resistance during the exhalation phase. So they start trapping air in their lungs, and they become hyperinflated. And so the lungs are extremely distended. Usually, when they try to exhale, the airways close so much that it accelerates the air coming out, and the accelerated air makes a sound. It's called a wheeze. Wheeze. And so typically, when a person with asthma is having an asthmatic attack, they have an expiratory wheeze. Sometimes you can hear it on inhalation, but it's more pronounced on exhalation, because that's when the airways collapse the most. In area of stenosis, that will increase the velocity of airflow through the area of stenosis. And that causes a kind of broadband sound we call wheeze. Okay. There are two types of asthma that we should know about. There's something called extrinsic asthma, and there's something called intrinsic asthma. Most important things for you to remember about extrinsic asthma. Excuse me. Young people, usually pediatric range, triggered by some sort of offensive antigen that's inhaled, mediated by a type 1 hypersensitivity reaction. So extrinsic asthma, young people, triggered by some sort of offensive antigen that results in an immunologic response culminating in a type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction. The second form of asthma we need to know about is called intrinsic asthma. The important thing to know about that, generally older patients, adults.
triggered by an imbalance in bronchodilators and bronchoconstrictors. It is not immunologically triggered. Okay, so extrinsic asthma, young, type 1 hypersensitivity reaction, immunologically triggered. Intrinsic asthma, adult, imbalance in bronchoconstrictors and bronchodilators, no immunologic trigger. Now, let's take a look at the extrinsic asthma first. So kids generally, this is a type of asthma that has a immunologic trigger. It's caused by a type 1 hypersensitivity reaction. I'll remind you what a type 1 hypersensitivity reaction, here it is. Okay, it is a reaction in which mast cells degranulate, releasing histamine. Here's what typically happens. You have a young child exposed to an antigen he or she is sensitive to. They inhale that antigen. The antigen enters into the airway and cross-links IgE immunoglobulin on the surface of these mast cells. In response, the mast cells release granules filled with histamine. Now remember the three things histamine does?
Vasodilate,
Permeability.
bronchoconstrictor.
Bronchoconstrictor. Imagine histamine being dumped on an airway that's already irritable. It's a bronchoconstrictor. You dump it on an airway that's irritable. That airway just goes into a spasm. And that's what triggers what we call the extrinsic asthmatic attack in the child. This type 1 hypersensitivity reaction. Okay, let's have a look at that. Remember, the airway contains a lot of mast cells. It's usually found in the subepithelial tissues. And here is a section through the airway. Again, you can see the lumen up here. There is the respiratory epithelium. And that's that protective epithelium. In this case, it's a purely conductive epithelium. Okay, it must be one of the purely conductive airways. Below that epithelium, we've got some subepithelial tissues, which includes this. That's the mast cell. There's its nucleus, and its cytoplasm filled with basophilic granules, all of which probably contain histamine. That mast cell won't do a thing until the IgE immunoglobulin on the surface is cross-linked by some sort of divalent antigen that will cause the mast cell to degranulate, releasing histamine. Okay, you dump that histamine on the already irritable airway. Histamine's a bronchoconstrictor. It's going to send that airway right into a spasm. And that will culminate in an asthmatic attack. Okay, take a look at that mast cell. Again, there it is. It's transmission electron micrograph. There's the mast cell. Okay, there's its nucleus. There's some connective tissue out here. And you can see the mast cell is loaded with granules. These electron-dense granules contain things like histamine and heparin. Histamine is the bronchoconstrictor. Now, there are a lot of things that can trigger an extrinsic asthmatic attack in a young child. The only thing required is that the child has to be sensitive to that antigen. Sometimes initially they're exposed to the antigen, they're not sensitive to it. But perhaps on a second exposure, by that time they have become sensitized to it, and they'll have that asthmatic attack. If they are the typical antigens that people are most sensitive to, who have extrinsic asthma, pollen, of course. We have the fecal material of dust mites, antigenic. We have salivary proteins of pet dander, and of course we've got mold. Typical history you get: a young patient with extrinsic asthma having an asthmatic attack. Child went over to a friend's house, played with kittens, no problem, and he went home. A week later comes back, plays with the same kittens, and has an asthmatic attack. What happened? During that 1 week, the child developed a sensitivity to the salivary proteins of the kittens. And exposed again, it caused IgE cross-linking on those mast cells degrade. Okay, any questions on this?
So older people can't have extrinsic asthma?
Older people can have extrinsic asthma, but often they will outgrow extrinsic asthma as they get older. I've heard that story many times. When they were a kid, they had asthma, now they don't have asthma. Yeah, so they outgrow the extrinsic asthma. Okay, we don't have any more time to cover